Hi, everyone. We're back for another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Aimee Eblen from Nashville Fertility Center. And today I'm joined by my co-hosts who are fun, friendly, and fabulous. Dr. Susan Hudson from Texas Fertility Center
Hello, everyone.
and Dr. Carrie Bedient from the Fertility Center of Las Vegas.
Hi, guys. Hello.
And we are also joined by a special guest today, Dr. Aimee. She is also known as the Egg Whisperer and a fertility expert. She's a reproductive endocrinologist in California, and she's going to talk with us in just a little bit about the importance of checking your tubes as a part of your fertility evaluation. But first, Aimee, you were telling us some really interesting things before we got started. We were asking you kind of what do you like to do? What's your fun thing? And you were saying you really like electronic dance music. So tell me a little bit more about that.
Yeah, I love to vibrate. I want to vibrate each and every day and take that as you want. But literally, like with what's going on in the world, we have to find ways to just build in joy into our
Yeah.
life. And as a fertility doctor, we have to be superheroes for our patients. You know what I mean? Like we have to, be here to inspire them as they also inspire us with their strength. And so I feel like the healthier I am, the happier I am, the fuller my cup is, the more present I can be for them. So, Carrie and Susan, Abby, you guys know that greatness is not just something that you're given. We are great doctors because we are obsessed with helping people, right? And so this
That's right.
obsession can be draining, right? It can be tiring. And so, I have my Sirius XM station. I have my liked, songs. I just go to them. I listen to them between retrievals, before retrievals. I have my music before transfers. I have my music before I go to bed. And it irritates the hell out of my husband. So that's why I watch Dateline. So I'm slowly trying to kill him. He likes Billy Joel. I like Diplo. It's very different.
So I would say in
So
San Francisco, you have some pretty good opportunity to go to concerts. I know I have a family member who's driven up there from Santa Cruz many times to see concerts. So how often do you go to see concerts, or is it more just kind of in your office you listen to
Oh,
that kind of music?
oh, both. We have the Fox Theater. We have festivals all
Yeah.
the time. I'm buying tickets left and right. I'm doing a Diplo run in September. Sophie Tucker is coming November 8th. So just excited about all the opportunities to, when I work hard, I work hard. And the 3 hours I get to like go to a concert, like I'm having a lot of fun.
You work
Absolutely.
hard and you play hard.
Do you take your husband to these concerts too, or do you guys have a no Billy Joel, no Diplo concert going
Yeah.
deal where you each go separately?
So the deal is I don't have to go with him, but he has to come with me.
Oh, wow. How do
That
you
sounds
manage
like a
that,
total
Aimee? How does
marriage.
that work?
Because he's very lucky to be married to me. That's what
Oh, okay.
every
Yeah.
morning before he wakes up, I whisper in his ears. I'm like, "You're so lucky."
Yeah, I'm gonna
And
try that
I
tomorrow
don't
and
have
see how that.
to
I'm gonna
listen.
try that for my husband, see how that works for me.
I know. Yeah.
It's
Well, very
subliminal.
cool.
That's
That's right,
amazing.
subliminal. So, before we talk to Aimee, we're going to answer a couple of listener questions. So, Susan, have you got a couple of questions for us?
I do. Okay, our first question is, hello, huge fan of your show, and I can't thank you enough for providing such important information to all of us out here looking for answers. You're welcome. Thank you for listening. I'm 36, partner's 39. I was given a diagnosis of PCOS once I started working with an REI. Egg retrieval in summer of 23 had 5 euploid embryos. First transfer was successful, but miscarried at 6 weeks. Second transfer was a biochemical pregnancy. Recently, I advocated to get tested for BCL6 thanks to your podcast, and it was positive. I've been on Lupron for almost 2 months, 3.75 milligrams each month, and planning for retrieval a retrieval soon. I have also asked to get tested for autoimmune diseases. I tested positive for anti-nuclear antibodies. Will this affect my chances of having a live birth?
That's for you, Susan.
Y'all go first.
So the autoimmune component of this, there's not a huge amount of really good data. So things go in and out of vogue in medicine, just like they do in fashion, music, and everywhere else. Autoimmune issues go in and out. And so we think there probably is some effect of the ANA. We just aren't 100% sure what it is, if the data is really locked down, because when you look at some studies, they'll say, oh yeah, there's more miscarriages, for example, with positive ANAs, but I haven't seen that anyone's really got a good treatment for it. Even when you look at steroids and some of the suppressive type things, those are not risk-free type treatments. And nobody's really put together a, if this, then this kind of protocol with, if you have positive ANAs, then you need to do XYZ. And so I think there's a lot of question marks out there about what to do. You certainly still can have, live births, healthy kids, all of those things. It's just, what are you going to go through between now and then to get there?
Yeah, I would echo that as well. There's just not a lot we understand about the immune system. I always talk to couples, particularly couples that have had recurrent pregnancy loss. If we took your husband's kidney and put it in you because if you were an HLA match and you needed a kidney and he could supply it, you'd have to be on all these immunosuppressive drugs for the rest of your life to keep from attacking and destroying that kidney. Whereas if he gives you his sperm and you have your egg and you get pregnant, we don't do anything for your immune system. We can put that same embryo in another person. There's nothing that happens with the immune system. So there's many, many, many things we don't understand about the immune system. The only thing that we do look at when it comes to the immune system is lupus anticoagulant and anticardiolipin antibodies. Those are antibodies that can potentially attack the blood vessels between the baby and you when you're pregnant. But like Carrie said, with ANA, we don't really know kind of what to make of that and what to do about it.
My contribution to this is realize that ANA is probably one of the most non-specific antibodies out there when it comes to autoimmune diseases. And so the thing you have to be aware of is it may not actually be the ANA that may be hurting you or hurting your chances. It's that you need to make sure that there's, you don't have any symptoms of another autoimmune condition that is treatable that we do know has direct relationship to things like recurrent pregnancy loss. So making sure your thyroid is working well and, we don't have, anti-thyroid, antibodies, those types of things. Celiac disease, if you have uncontrolled, undiagnosed celiac disease, that can also increase your risk of miscarriage. And really almost any non-controlled autoimmune disease is going to potentially increase your risk of miscarriage. But unfortunately, as we said, there's not a direct link to you have a positive ANA, you need to do this. This is going to equal positive and successful pregnancy test. Aimee, what are your thoughts?
Yeah, I mean, I have patients that reach out to me all the time and they actually request these tests. And I say, I'm happy to order some of them for you. So if someone's ANA comes back positive, just like what Susan said, I say it's a very non-specific test. Just because it's positive doesn't mean that there's anything wrong with you. And if it comes back positive, you don't have joint pain and unexplained rash, I'm not really too worried about it. But if you're someone who still feels like something might be wrong, I refer patients to a rheumatologist just for extra reassurance. And almost always they come back and say, I don't see that this is a test that's really going to help guide you with your fertility journey.
All right, let's do one more. First of all, thank you so much. And I love your podcast. I have recovered from an eating disorder. I'm at a healthy weight. I'm 32, trying to conceive for 10 months with no luck. I do not have a period, but actually had positive urine ovulation over-the-counter tests. I am taking progesterone now for 10 days and planning to get labs with my OBs on day 3 after a bleed. Hopefully I bleed as I have bled over the past withdrawal, then ultrasound and HSG. Any tips? Do you think I will respond to oral meds, Clomid or letrozole, to help me get pregnant? Thank you.
So she's got positive OPKs, but no periods. Did I hear that right?
Yeah.
So my question for this is, does she really have positive OPKs indicating ovulation, or are they just positive OPKs because she's got an LH that is just high enough to trigger the test to turn positive? And so one thing to think about when you're doing OPKs is you should see negative, 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 all the way up to the point of ovulation. You should see positive for a day, maybe 2, and then it should go back to negative. If you're getting kits that are constantly negative, all the time positive, or surfing the line between the two where it's going into positive, negative, back and forth, you're probably not ovulating, and those kits are probably not super reliable for you. The kits in general are pretty reliable, but for you, you may have just enough higher levels of those particular hormones to have it not be the instructive piece of information that you really want it to be. So my guess is that you're not actually ovulating and that those medications may actually be helpful for you, assuming that everything else is well behaved, like, partner sperm, tubes being open, those types of things. What do you guys think?
Yeah, and I think regarding medicines, I think the good news is I always kind of joke with my patients with PCOS and say, I'm happy to see you for this condition because this is one of the most easily treatable conditions that we have. About 80% of people respond to medications. Several years ago, 15 years ago or so, we used to start out with Clomid. Now we tend to use letrozole, and the other name for that is Femara. And we start out with that. And ultimately, we start out and increase the dose as we see appropriate if you don't ovulate. And certainly, if the letrozole that we usually would start with first now doesn't work, then we would switch to Clomid. But ultimately, patients tend to be really successful in terms of achieving ovulation with PCOS. And usually, if they're able to achieve ovulation, they have a really high likelihood of success, provided there's not some other fertility issue involved.
But with the history of eating disorder, I'm a little concerned about her brain and ovaries not, even with the oral medicines, talking to each other. If somebody really wants to avoid injectable medications, I will sometimes give them a trial of kind of maybe oral plus injectables, a little bit of a combination cycle, to see how little we can get away with. But I would say understand that even though you are in recovery from your eating disorder, sometimes the brain and the ovaries just never truly have that innate connection that they used to, and that you may need to use a medication like Menopur that will help kind of make you ovulate and really provide both of the hormones that are necessary to stimulate good egg growth in this type of situation. It doesn't happen with everyone, but know that you're probably at a little bit of a higher risk of needing medications like that. But again, walking a very fine line potentially of not recruiting eggs versus recruiting too many eggs, because as much as we want you to have a baby, we don't want you to have a litter of babies.
Any
Right.
thoughts, Aimee?
Yeah, I would just say, just get your AMH checked right now. I mean, I think what we want to know is maybe this is decreased ovarian reserve or primary ovarian insufficiency. And that would be a good thing to rule out sooner than later rather than waiting for some, a period. And then, get seen, do some tests, rule out hypothalamic amenorrhea versus PCOS. I totally second, third, and fourth everything that you guys are saying. And just always check your tushy before you start treatment. And I think we're going to talk about my tushy very
Exactly.
soon.
One thing I did want to mention that with this history of eating disorder, I would probably get myself to a reproductive endocrinologist sooner than later, because your OB-GYN is going to feel comfortable with just Clomid, just letrozole potentially, but they're not going to go into that next step of potentially using injectable medications. So probably get an appointment sooner than later is probably a good idea.
Great. So we are going to talk to Dr. Aimee today. She's also known as the Egg Whisperer and also has a podcast. So I want to make sure that everybody checks that out. She's going to talk to us today about the importance of checking fallopian tubes. She's a reproductive endocrinologist in the San Francisco area, and she's specifically going to talk a little bit about ExEm Foam, which I'll have to admit, I'm not real familiar with that. I don't usually use it, so I'm really anxious to hear and excited to hear about what you have to say.
Well, I think it's an awesome way of checking the tubes gently. I think the name of the test should be the gentle tube test. Doesn't that
Patients
sound
would
nice?
really like, I think the patients would really like that because they're always terrified when we talk about checking their tubes.
Yeah, I mean, the HSG is barbaric. Patients aren't offered pain medication. I offer all my patients a Valium and a Tylenol with codeine 30 minutes before their HSGs. So their experience is a lot different than 99% of women's experiences out there. And then they read online about it, and then they're just like so scared, so fearful. And it just shouldn't be that scary, right? Like getting your tubes checked should be easy. And we know that one of the most likely reasons for infertility are tubal blockages. You know, some statistics are as high as, let's say, 15%, and that could be from a previous pelvic infection, endometriosis, pelvic surgery, for example, or it's just how you were born. There are conditions like, for example, salpingitis ischica nodosa, and it might be something that you could have been born with or acquired over time. And then the fallopian tubes are where the egg and sperm meet. It's like the meet and greet spot. You know, it's where the sperm presents the rose to the egg. And the egg can be like, no, thank you. So if that spot in the whole magic of making babies just isn't open, if the parking spot is blocked and there's tape all around it, like scar tissue, it's just not going to happen at home unassisted. And so I've seen heartbreaking stories, and I know you guys have too, where really well-intentioned OBGYNs have given their patients like 12 months of Clomid, not done a single semen analysis, no tube test, and then like their hopes and prayers every month, please let this work. But it just never could have worked in the first place because the tubes were blocked.
Hey, Aimee, can you back up for just a second and just talk about a little bit about the how the egg and the sperm get together? Because I think a lot of patients don't really understand how important the tube is and where fertilization actually occurs in the tube.
Exactly. So once an egg drops, it just basically gets picked up by the ends of the fallopian tube. And the ends of the fallopian tube basically say, come to me. Okay. So once the egg goes in, if the tube's open, then the sperm actually is hopefully waiting for the egg. Okay. So that's why I always tell patients to have sex starting 3 days before ovulation, so that sperm is waiting. Okay. Because eggs don't wait for anything. They'll sit there maybe 12 hours, maybe 24 hours, and they're like, see you later. So you want sperm there. And that's where they actually meet. So sperm will enter the fallopian tube and sit there. Some say up to 6 days, some say up to 3, but it just kind of depends on how strong that sperm is, of course. And then hopefully they can meet in the fallopian tube. So if the tube's not open, sperm won't be able to enter. If the tube's not open, the egg can't get in. If the tube's not open, the egg and sperm can't meet. But if they do meet, and if this tube is a little bit open and maybe it's a little bit inflamed, your embryo can actually grow and divide. And over the course of a week, it can try to travel down the fallopian tube. But as it's traveling, what's happening? It's getting plumper and plumper and plumper. And then it can get stuck. And when it gets stuck, that's one of our worst nightmares. We don't like emergencies as fertility doctors. We don't like
know why we went into this.
No. So that's a big deal for us. So that's another reason why I really like to make sure a patient's fallopian tubes are open, even before IVF, where people say, like, why does it matter? Like, why do I need to know if my tubes are open? I'm bypassing the tubes anyways. And I'm like, you actually have a higher risk of ectopic pregnancy from an embryo transfer than you would in an unassisted pregnancy. And I don't like emergencies. And I just don't want you to go through that.
So to be clear, even if you think it's your husband doesn't have a good sperm count, or even if you think you're not ovulating, does a patient really still need to have their tubes checked?
I think it just depends on the situation. It's part of my checklist. The answer is no, you don't really need it. So if you're anovulatory and the sperm is bad, do you need to check the tubes? No. It's lower on the list. It's going to be a pretty low yield test for you, especially if you're going to go to IVF. But if you're hoping to have an unassisted pregnancy, or you're going to do IUI, I think it's very important to check your fallopian tubes first. And sometimes I tell patients, look, let's try one cycle without checking. And if you get pregnant with your first IUI, amazing. But if it doesn't work the first time, then I think it makes sense to check your fallopian tubes.
Yeah, it's definitely something you don't want to leave out, right?
Can you talk a little bit about the effects of swollen fallopian tubes or hydrosalpinx?
Yeah, so water salpinx tubes. There's just a water-filled fallopian tube, and that fluid inside is not embryo friendly. I don't like to use the word toxic, but that's kind of what it is. So imagine the fallopian tube is connected to the inside of the uterus through these little holes called tubal ostia. And that fluid can float in, and just imagine a surfer. And then there's like this really big wave. That embryo sees that wave of fluid that's not so friendly, and it'll take the embryo out. That embryo is just going to get knocked off their surfboard, never able to attach. And it's tragic. So, an embryo can start to attach, and then hydro could potentially cause a biochemical pregnancy, which is where the embryo just attaches just for a short period of time, and it just can't continue to grow because of the inflammation that's surrounding it. another thing that can happen is an embryo can float up into the fallopian tube. And if there's a big fat hydro, that fallopian tube can't do the snake, right? It can't move that embryo back into the tube. So it's like, buddy, you're stuck with me. I'm sorry. And then we get to what we hate, every fertility doctor's nightmare, the ectopic pregnancy. So then you might face an ectopic pregnancy situation when you transfer also with the hydrosalpinx.
What are some of the different ways you can test tubal patency, or whether or not tubes are open or not?
Yeah. So my preference is the gentle tube test, which is the ExEm Foam, which uses a type of ultrasound contrast agent that lights up on the screen. It's like fireworks on the 4th of July. It is so fun for me to do. And I try and like temper my enthusiasm, because I think it's a really weird when your fertility doctor's like, oh my God, that's so cool. And you're just looking at someone's tubes. But it actually is that cool to me. It's just nice to know that patients are comfortable. They're not screaming in pain. They don't have to be hooked up on drugs as well. So there's that test. There's also the hysterosalpingogram. So that uses X-ray or fluoro, and it's usually done in an imaging center. So if I have a patient, or before I was offering patients the hyphosi with ExEm Foam, I was referring patients for HSGs at an imaging center. It's the same idea, speculum in, catheter in, and rather than pushing the foam in, you're pushing a radio opaque dye. Okay. There's also laparoscopy. So laparoscopy is a surgery under anesthesia. It's minimally invasive. And this is something that we used to do 15 years. You walked into a fertility clinic 15 years ago. What did we do at our initial intake? Yep. Sign you up for a laparoscopy.
That's right.
It's very different right now. So now we have these tests that we can do without putting patients under. And the reason why we do these tests and not run to laparoscopy is because back in the day, IVF pregnancy rates were not as good as they were now. So we really had to spend so much more time trying to figure out what was wrong and how we can fix it, because we just didn't have these tools that we have today. So those are basically the 3 tests. But there is another way of checking tubes that's somewhat similar to hyphosi, and that is the FemVue test. It's kind of the same concept where you can push bubbles through the fallopian tubes. I've also been doing that test for a really long time, for almost 15 years, but I just think the visualization that you get with the foam is just so much more beautiful, and it's a lot easier to see the entire length of the fallopian tube, and you can sometimes even see the fimbria at the very end as well.
So can you kind of break that down and kind of tell me a little bit more specifically, for people that don't have a medical background, what's the difference between the foam and what's the difference between the other tests that you used to do, where you put?
Saline tests, you can actually see the bubbles. So imagine you're blowing bubbles into a glass of water. So you do something with the syringe. So there's a little technique that you use to push bubbles of air through the foam. So that's one way of seeing it, but the foam is a little bit different. So it lights up the fallopian tube in a different way. And so you can actually see as the foam is traveling through the fallopian tube because of it being a contrast agent.
Would you say that's probably more sensitive to diagnosing not only if tubes are open or not, or like checking for those hydrosalpinx or healthy fallopian tubes?
Absolutely, because you can actually see the diameter of the fallopian tube as it travels, as the foam travels through it. I'm not sure I've hit like 200 of these tests yet, but I'm yet to diagnose a hydrosalpinx by doing the test. So if I see an obvious hydrosalpinx on ultrasound, I actually will not perform the test, which makes sense.
Right.
And
if you can see it negative on ultrasound, it's huge.
Yeah. Why put her at risk of a pelvic infection? No, thank you.
Tell us about that. So what is the risk involved with these types of tests that you just mentioned?
Yeah. So there's a reason why sometimes we ask patients to take an antibiotic the night before and the morning of. And then if the tubes are open, patients can stop the antibiotics. If they're blocked, they'll continue it. There's a very small risk of infection. It's about 1%. I have personally seen, this was years ago. This is about 17 years ago. There was a patient, it was when I was in training. She actually had uncontrolled diabetes. She had bilateral hydrosalpinx, and we had to admit her to the hospital because someone ordered an HSG on her, knowing she had those 2 things. And that just caused a massive pelvic infection. So it can happen. It is rare, but when it happens, it's so serious that's why we pay very careful and close attention to, a whole patient's story before we just put them through a test like this.
So
Yeah,
when
absolutely.
when you're using the foam, so we know that when you're using like the saline and bubble solution, that's a fairly benign type of solution to put through. That's not going to cause any problems. The radiopaque dye that we use for HSGs, we've been using forever and ever, amen. So there's a fair amount of data there. What is the foam made out of? Does it cause any issues? Is there any scar tissue from it? Do people have allergic reactions to it? What's that part of the story?
Yeah, I have not had a patient have any type of allergic reaction to it at all. Give me 1 second. You guys edit this, right?
Yes, we do have a great sound editor.
Okay, good. Let me find the section on what the hell this stuff is made out of. Let me see. I don't know what it's made out of.
Is there, while you're looking for that, do you know if it has any like iodine containing, like, is this a good option for somebody who has an iodine or severe shellfish allergy?
Yes, it is a good, let me just see here. I mean, it's called air polymer type A. There you go. That's why I call it a polymer. So it is a good option for people who are allergic to iodine or shellfish.
Oh, good.
Cool.
So it dissolves pretty quickly. It doesn't hang around in the system, doesn't
No.
Okay. Because
No.
that's another thing that I always think of whenever you're putting some foreign substance in there whatsoever, especially when you've got like patients who are prone to endometriosis, where there's that autoimmune inflammatory reaction. Is there going to be any kind of response to the material that we're using to check the tube? So knowing that it's something that dissolves quickly and doesn't elicit that response is huge.
Well, and
Yeah.
another example of that is HISCON, back when we used to do a long time ago with hysteroscopy, that, a certain percentage of patients had a severe allergic reaction. So that's a great question, Carrie, to ask.
Yeah. Yeah.
So once you have that tubal testing, what findings are good enough for you to say, okay, this is really solid information and we're going to base our entire treatment plan over this, versus what might make you say we need to do a little bit more evaluation, or this is more uncertain in terms of, are the tubes truly open, are they truly closed? Like, what's the reliability of all of these tube tests?
Yeah. I mean, I would say that there is always a likelihood of a false positive. So there's something called tubal spasm that can happen. The uterus is a muscle. And so when you push something into that muscle, it can contract. And when it contracts, it can make it look like your fallopian tube is blocked when it really is not. So, so I always tell patients, the test tells us, according to this test, it's blocked. But at the same time, this is not 100%. Even when you go to laparoscopy, sometimes you can have tubal spasm. But I would say if you're a patient who's been trying for, let's say, 3 years, and your HSG shows blocked tubes, sperm is good, you're ovulating, that's likely the reason why.
It makes sense.
It totally makes sense. So I have had patients where I've done the ExEm Foam test on them, and their uterus is, let's say, severely retroverted, and I'm not seeing that the tubes are, that I see the nice passage of the foam. And in those types of cases, sometimes I will order an HSG on them. So I've only had to do that in 2 patients so far. And in both of them, they actually had open fallopian tubes. So that's why I'm very careful about telling patients you definitely have blocked tubes. And it doesn't mean you can't do the test on patients who have a retroverted uterus. But when you see as many people as we all do here, you can tell when you feel really confident about someone's results versus when you feel like they should have a follow-up test done.
Do you feel more confident that you truly have blockage if you see a certain amount of the fallopian tube fill up and then it stops, versus when it's right there by the uterus?
Absolutely. Absolutely. And then one thing I might add is that to make things convenient for patients, I actually sometimes do this test while they're asleep for their egg retrievals. So they're already asleep. This is for patients who have already, known obviously that they want to do IVF, but for whatever reason, we still want to check the fallopian tube. Let's say they have a history of recurrent implantation failure. We want to make sure that we're not missing anything. I'll sometimes do this test while they're asleep.
And if you find that they have a block kind of where the tube connects to the uterus, the corneal region versus the far end, the distal region, hysterosalpinx, what would you do differently in, say, that patient that's going to do IVF or is in the middle of an IVF cycle?
Not much. I wouldn't. How about you? I wouldn't really necessarily do anything differently myself if
But I mean,
they're
surgically before embryo transfer, would you consider removal of the tube or surgery on her for any reason?
absolutely. So it also depends on how many embryos she has left, because I want to make sure that she's not, if it's a hydrosalpinx, without a doubt. If it's just a blockage, I'll just talk to her about her risk of ectopic and give her the option of removing them. It just really depends on how many embryos she has and what her feelings are about removing her tubes.
But in the case of hydrosalpinx, the reason why we want to remove that tube is because we can decrease your chances of success by up to 50%. That's 50. There's not a whole lot of things other than using nicotine that are going to decrease your chance of success that much. And so
stopping your progesterone, maybe.
Yeah, it's a modifiable factor that we can change and actually improve your chances of success of that little embryo sticking.
Mm-hmm. Now, I want to back up about 4 minutes. And you had mentioned patients who have a retroverted uterus. Now, this is a slight detour from our original topic, but we get questions all the time of, oh, my ultrasound said, my OBGYN said, whatever, however I got this information, I have a retroverted uterus. I need you to know that. And does that ever impact what you do and how and why?
For me, it does, because sometimes someone can have a severely retroverted uterus because of endometriosis. So severe endometriosis can cause the uterus to be pulled back and fixed. And that is a very serious condition, as we all know. It can rob a young woman of the ability to carry and the ability to even have healthy eggs if not caught early enough. So I find that finding to be really helpful for me. But in general, just a regular tilted uterus is something we all have. Everyone has a tilt, whether forward or back, but retroverted does not mean you're going to have a harder time getting pregnant or pregnancy complications unless it's associated with a condition like endometriosis.
Mm-hmm. One thing I want to mention for this, when I was in fellowship at Mayo Clinic, we had this great electronic medical record that we could actually draw the position of the uterus at our trial transfer.
That's really cool.
It was great. I mean, you could include the flexion, you could include everything. And I can tell you, no one ever taught me before that moment that the uterus can move. And I don't know how many times that we would go and you'd do your saline ultrasound, you'd have this great electronic picture, you go in for your embryo transfer and you're like, this is not what was drawn. And I'm absolutely certain it wasn't because of our lack of artistic abilities, because it really was not hard to do this on the computer generation. And so, know that we think of your uterus as a stagnant organ, but know that it can move in position due to different things happening in your body. So, it's things that we pay attention to, but don't get all freaked out about when somebody's like, oh, you have a introverted uterus or retroflexed or, that type of thing.
Yeah.
Yeah.
Well, back then too, Susan, we did fresh transfer. So remember back then you might have the check done a few months in advance, and then they have these big ovaries and the uterus is like propped up on the back of the big ovaries and all that. So yeah, uteruses definitely move. Well, very good. So Aimee, what is a question I've not asked you? Is there anything that we've missed here that we need to discuss, or do you think we've covered this well?
I think so. I mean, I think one of the things, like, when in your cycle do you usually do it? So I usually do the test after your period's over, before ovulation. So you can give someone fixed days, like cycle day 8 through 10, but that might not work for everyone's schedule. So I think just using your common sense and talking to patients about when your period's over before ovulation, because everyone's window is going to be different, is when I do the test. They don't need a driver. They eat and drink before they come in. You can do it with an empty bladder. You don't have to have a full bladder for this test. I like it to be just a little bit full in case I need to use abdominal ultrasound guidance to get the catheter in, but I've never had a problem getting my catheter in for this test. And I basically just use an IUI catheter. You don't need a balloon catheter for it. So there's none of that pressure on the cervix that can make women get vagal and pass out. And I haven't had a single vagal reaction either.
Awesome. Yeah. All right. Very good. Any other comments?
I think we're good. I learned a lot today.
Yeah.
Excellent.
Awesome. Well,
Because
thank
you
you.
are
It's so nice to meet you all. Maybe are you guys going to any meetings like MRSA, MRSI, or anything like that coming up?
not in the near future. I'm at home working for now.
Yeah.
So
Yeah.
we've got a meeting next month, and then of course ASRM
Okay.
is hopefully this year. We'll see. I know all three of us are planning to go next year, but
Yeah.
we'll just kind of see how the rotation for our practices goes.
Nice. Well, hopefully I'll get to see you guys at some point in person. Well, thank you for
Yeah.
I appreciate it. Have a great day. Talk to you later. Bye, guys. Bye.
Bye. To our audience, thanks for listening and tune in next week for more. Also, be sure to subscribe and leave a review in iTunes. We'd really love to hear from you. You can follow us on Instagram or Facebook. So please hop on and leave us a like or a comment.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment, so don't hold back. We love episode ideas, so let us know what you're thinking and what you want to hear.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon.
Bye.
Bye.
Bye.